Hello everybody. Our topic today is Approach to Arthritis by Rheumatology, Rehabilitation and Physical Medicine Department. Before going through the lecture, please revise the Word file attached to the PowerPoint presentation, which will explain some terminology we are going to use during our lecture. By rheumatic disease, we mean group of disease characterized by pain and inflammation in joint and connective tissue. It's common for patients with rheumatic disease to come presenting with one of these three manifestations: joint pain, joint swelling, diffuse or systemic manifestation. And through the history and physical examination, we have to check: is his manifestation articular or not? Is there any signs of inflammation? How many and which joints are involved? Is it acute or chronic manifestation? Is there any other constitutional or systemic involvement? And last but not least, are there red flags or not? Though it is not the most common, but still the red flags are conditions that need immediate medical intervention because of high morbidity and mortality. So we have to exclude at first the red flag condition. And also we have after that to put the differential diagnosis of the condition according to which comes commonly, because common things come commonly. And we have also to put in our mind that many rheumatic diseases are self-limiting. So the natural history of the disease are showing remission and exacerbation. And also we have to put in our mind that some of rheumatic disease needs several visits to the clinic. That means that some symptoms may appear and disappear in different situations. And also we have to put in our mind that the major stay of management, that we have to provide relief, reassurance, and plan for evaluation and treatment because of the natural history of the disease. So how to exclude the red flag conditions that need immediate intervention? First, we have to exclude fracture by asking the patient about history of trauma and presence of local pain. Second, we have to exclude having infection. Usually the patient comes with many constitutional symptoms like high fever, sign of toxicity, and of course sign of infection like swelling, and sometimes there is a penetrating injury around the joint, or the patient is immune compromised. Third, organ involvement. Also we have to exclude organ involvement like renal affection, hepatic affection, neurological manifestation, which will alter our management. So those are the most common three red flags we have to exclude before going through the patient history and examination. After excluding the three red flags, what should we do? According to the scheme we mentioned before, we have to diagnose: is it articular or periarticular? By articular, I mean the affection is inside the joint, and periarticular, I mean in the surrounding tissue of the joint, like bursa, tendon, and so on. On clinical basis, in the articular involvement, the pain is diffuse, and the patient feels that the pain comes from deep tissue, and of course there is deep tenderness. On the other hand, in the periarticular, the patient does not feel a diffuse pain, but he can point to the painful point with his finger to the painful point. Regarding the range of motion, it is painful in case of articular affection in the active and passive uh, range of motion. By active, I mean the patient himself moves the limb. Passive, the examiner or the physician, he is the one who moves the joint. In case of periarticular, only the active motion is painful, because in this active motion he uses the muscle, tendons, and so on, but the passive only moves the joint but not the surrounding tissue. The swelling is common in case of articular, but it is also present but not commonly in periarticular affection, but it is there. First, we have to exclude the red flags, and after that, after exclusion of the red flags, we have to go for the second step to check is it articular or not. If it is articular, third point, we have to check is it inflammatory or not. And by inflammation, I mean the cardinal sign of inflammation: redness, swelling, pain, and loss of function, which are the character of inflammation anywhere and also in the joint. If there are signs of inflammation, we label the patient as inflammatory arthritis. If the patient comes just with pain, we label it as arthralgia. So arthralgia is not inflammation of the joint, but arthritis is inflammation of the joint. So once more, we excluded the red flag condition. Then we checked is it articular or not. The third step that we differentiate between inflammatory and non-inflammatory affection of the joint, which can be done through the clinical manifestation of pain, swelling, erythema, and warmth, and which are of course cardinal sign of inflammation, as I mentioned before, which are not present in the non-inflammatory conditions. And I will stress on the morning stiffness because it is one of the most important feature of inflammatory arthritis, that is morning stiffness, which is at least for 1 hour in cases of inflammatory arthritis, but it doesn't last for 60 minutes. It is less than 60 minutes in non-inflammatory conditions. At this point, we have some differential diagnosis. We encountered patient, we excluded the red flag, then we went is it articular or not, then is it inflammatory or not. At this point, we can check this table to get the differential diagnosis from question 1 and question 2. Is it inflammatory? If it is inflammatory and affection the joint, it can be septic arthritis, gouty arthritis, rheumatoid arthritis, or psoriatic arthritis. And if it is articular but not inflammatory, osteoarthritis with question mark as we mentioned, charcot joint or fracture. If it is non-articular, I mean it doesn't affect the joint itself but affects the surrounding of the joint, surrounding tissue of the joint. If it is inflammatory, it can be bursitis, inflammation of the bursa, enthesitis, inflammation of the soft tissue attached to the bone like tendon, and polymyalgia rheumatica and polymyositis. If it is non-articular, non-inflammatory, it can be fibromyalgia or carpal tunnel, which you will later on know about. To the next question. How many joints are affected? If it is one joint only, we call it monoarthritis. If it is 2 or 3, we call it oligoarthritis. If it is 4 or more, we call it polyarthritis. And these are less of some common causes of oligo and polyarticular affection. By acute in rheumatology means that is hours or maximally days. By chronic we mean 6 weeks or more. So the chronic arthritis is affection of the joint for 6 weeks or more, and this is a list of some diseases calling either acute, chronic, intermittent. By intermittent we mean that it comes in bouts, then it is either completely resolved or partially resolved. Additive, that means each time more symptoms and signs are showing. Migratory means it affects joint, then it leaves this joint and affects some other joint. In this slide, we show some of the acute versus chronic inflammatory arthritis. Actually, I would like to stress on 2 points. First, that the acute arthritis can be seen in trauma, in gouty arthritis, and in septic arthritis. And usually it is monoarthritis. So the most common differential diagnosis for acute monoarthritis is trauma, gout, and infection. And the second point, I would like to stress that chronic arthritis is usually comes in cases of inflammatory arthritis, and it is associated with rheumatoid arthritis, ankylosing spondylitis, systemic lupus erythematosus. So again, this slide summarizes the causes of acute and chronic inflammatory arthritis. And during history, we have to get some clues to get to our diagnosis. And usually in the history, we ask about age, sex, race, and so on. That are because some diseases are common in certain age group, and some diseases are common in special gender, male or female, and some diseases are common in some races. And for example, if we have a young patient complaining of um, chronic arthritis, chronic inflammatory arthritis, for a young patient, of course, our mind goes to disease occurring in young age, and usually it is idiopathic juvenile arthritis, which was formerly called uh, chronic juvenile arthritis, lupus, which comes in young female or mid-aged female, and um, if we have an old patient, we have to think about osteoarthritis, which is partially degenerative, partially inflammatory arthritis, and of course some rheumatic disease common in female like rheumatoid arthritis, lupus, and some are common in male like ankylosing spondylitis. And some disease runs in race or more common in special race, like for example Bahsa disease, which comes from the name Bahgat, which is a Turkish person, so it is common in those population. And Takayasu arthritis, from the name that it is known that it is common in Japanese, and so on. Although I do not like the condensed slide, but just I inserted this slide to show you that the rheumatic disease can affect any part of the body. You do not have to memorize everything. Just put in your mind that rheumatic disease is not confined to the joint, but can affect all the body systems. First, you have to differentiate between constitutional and extra-articular manifestation. Constitutional manifestation is symptoms and signs which are not disease-specific. You can find the fever, the fatigue, the malaise, the loss of weight, and the loss of appetite in many other diseases, and it is usually by circulating toxins. And again, it is not disease specific. But the systemic or extra-articular manifestation, which are symptoms outside the joint, but it still carries the same pathology of the disease. So it is disease specific. When you check the eye and you find some manifestation in patient with rheumatic arthritis, you know that this is the same pathology like what is happening in the joint, but it happens in other body systems and so on. So this slide just to show you that many other organs can be affected in many rheumatic disease, and also it shows the difference between constitutional disease and extra-articular or systemic manifestation. By previous slide, we knew that many organs are affected by rheumatic disease, and this slide is the other side of the hill. I mean, this is the disease causing the manifestation. So the previous slide showed which are the organ affected, and this is what are the diseases affecting this organ. Again, it's not sort of memorization, it is just to give you a broad view that the rheumatic disease can affect many organs outside the joint. If you have to select one slide from the whole presentation, you may select this slide. This algorithm summarizes the whole presentation. I mean, starting with the patient coming to you with musculoskeletal manifestation, and first you have to do a history and examination for the patient and exclude the red flags. Then you go to, is it articular or not? So if it is articular, you have to check, is it chronic or acute. If it is acute, you have to put yourself on the differential diagnosis of acute arthritis. If it is not, you can go to the chronic. After 6 weeks of the disease, you can go to the chronic inflammatory condition. Then you go to which type of chronic inflammatory according to how many joints are affected, and then you do some your own investigation and check which joint are involved. Then you go to your diagnosis. This is a very nice algorithm. I advise you to copy and keep it in your pocket during your whole study of rheumatology. We have chosen 2 examples to apply the previous knowledge we had. I've chosen the rheumatoid arthritis as an example of chronic polyarthritis. As we all see, rheumatoid arthritis is not a joint disease merely. It is affection of many organs rather than a joint. Lung is affected, eyes affected, blood vessel is affected. So it is a systemic inflammatory disease rather than joint disease. Important to know what's meant by natural history. By natural history of the disease means the normal course of the disease. In rheumatoid arthritis and other rheumatic disease, the natural history of disease is exacerbation and remission. That means the patient shows some manifestations and this manifestation disappear, and so on. So it is a chronic disease with exacerbation and remission. That means the manifestation may rise, then disappear even without management, without treatment. And also it is a systemic disease, as we mentioned before. That means affection of the joint and the organ outside the joint. No one is immune regarding the rheumatoid arthritis. Rheumatoid arthritis can affect all age group, all ethnic group. Globally, it is a global disease, but there is some incidence rate higher among certain age group between 30 and 50 years, and women are more affected 3 times in rheumatoid arthritis than men. Regarding the causing of rheumatoid arthritis, it is still unclear what is the etiology of rheumatoid disease. And 2 major etiologies are claimed to be either autoimmune etiology or genetic factor, and they may both participate in the etiology and the pathogenesis. Autoimmune, by autoimmune I mean that the body recognizes the self-antigen the own self-antigen as a foreign antigen and start to destroy it. And the genetic factor that explains the genetic predisposition of some patient or some person to the rheumatic disease, and some environmental factor that evoke the genetic factor and make it causing the disease. But up till now, the clear etiologic factor for rheumatoid arthritis is still unclear. As we studied before, the joints are many types. One of them is the synovial joint. Rheumatoid arthritis is the disease of synovial joints, as shown in the photo. It affects mainly the synovium. The pathology is there in the synovial. And the pathology is collection of chronic inflammatory cells, which is called pannus formation. In the previous slide, the immune reaction of rheumatoid arthritis leads to aggregation of the immune cell in the form of the pannus formation with production of many active materials, which leads to destruction of the underlying tissue. One of the destructed tissue is the bone, causing what's called bone erosion, and also other tissue are destructed, leading to the deformity of the joint as seen in the photo. As we mentioned, rheumatoid arthritis affects the synovial joint of the body, but it has special preference to the small joint of the hand and feet. Other joints also can be affected, but with less frequency. And when the joints are affected, it is affected with certain pattern, symmetrical affection. That means same joint affected bilaterally. Rheumatoid arthritis is a deforming disease that causes deformities of the small joint of the hand, which affect the activity of daily living of the patient, and this is one of the major complications of rheumatoid arthritis. Coming to patient manifestation, the patient usually comes with morning stiffness of the small joint of the hand that lasts at least for 60 minutes. The stiffness mainly affects the metacarpophalangeal joint and proximal interphalangeal joint. Typically, the distal interphalangeal joint are not affected in rheumatoid arthritis. Also, the swelling of the finger can give the shape of spindle shape because of affection of the synovial hypertrophy and thickening of the capsule. As I mentioned before, the affection of the joint in rheumatoid arthritis is symmetrical. That means both sides are affected in the same time. And the patient usually shows an increase in the joint pain after periods of inactivity. And usually there is sort of tenosynovitis. Tenosynovitis means inflammation of the tendon synovial sheath of both extensor and flexor tendons around the wrists. This slide is just to press on the extra-articular manifestation or systemic manifestation of rheumatoid arthritis. Almost all the body systems are affected in rheumatoid arthritis, and the same pathology is seen in these organs. Of course, we cannot enumerate all the extra-articular manifestation of rheumatoid arthritis at this level of study. And we have just to mention the most common extra-articular manifestation here. First, the most common one is the subcutaneous nodule, which is almost present in 1/3 of the patient of rheumatoid arthritis. And usually it is present when the inflammation is high and the rheumatoid factor is positive, as we will mention later. Also, it is common in special HLA group, which is HLA-DR4. The second manifestation is the Sicca syndrome. Sicca means dry. So it is the dryness of some of the mucous membrane in the eye and mouth, and this is called Sicca syndrome or secondary Sjogren syndrome. It affects around 10% of the patient of rheumatoid arthritis. The third is the pleuropulmonary affection. That means affection of the pleura and the lung, which are also present in almost 10% of the patient. And fourth syndrome, which is called Felty syndrome. Felty syndrome is rheumatoid arthritis with neutropenia, which is deficiency of neutrophil, and splenomegaly, which affect also around 10% of the patient with rheumatoid arthritis. Those four are the most common extra-articular manifestation of rheumatoid arthritis. Little bit we'll have some details of them. As we have seen in the previous slide, the photo of subcutaneous nodule affecting the extensor surface around the elbow, and it is a collection of chronic inflammatory cells below the skin, and as mentioned before, it affects almost 1/3 of the patient with rheumatoid arthritis. The second one was the Sicca syndrome that comes with dryness of the mucous membrane, mainly of the eye, and the patient comes complaining of burning and gritty sensation and sometimes itching of the eye. And also it is usually presenting with decrease of tearing and photosensitivity. Photosensitivity means sensitivity to the light. Another manifestation of extra-articular manifestation of rheumatoid arthritis is the Felty syndrome, which is splenomegaly, neutropenia, and rheumatoid arthritis. This triad is the main cornerstone of diagnosis of Felty syndrome, and it is usually in the severe form of rheumatoid arthritis and in the nodular form, nodular forming rheumatoid arthritis. Nodular forming is the patient with subcutaneous nodule. So subcutaneous nodule is an item of Felty syndrome as well. We can divide the complication of rheumatoid arthritis into complication of the joint disease, complication of systemic manifestation, and others. The complication because of the joint affection is the joint destruction, which really begins as early as first year of the disease if the patient is not treated. Of course, the treatment can delay the joint destruction, and also affection of soft tissue leading to flexion, contraction, and deformities, which affect the activity of daily living of the patient. Mainstay of rheumatoid arthritis diagnosis is the history. After that comes the physical examination, then the investigation. We collect blood for rheumatoid factor, which is an immunological test which is not specific because it is positive in some other cases rather than the rheumatoid arthritis. Also the erythrocyte sedimentation rate and the C-reactive protein, which are two of the acute phase reactants which are raised in all inflammatory conditions, including the rheumatoid arthritis. Again, both are not specific. Then comes the anti-nuclear antibody, which are seen in some cases, and the most sensitive one, which is the anti-citrullinated cyclic antibody, anti-CCB, which has high specificity towards diagnosis of rheumatoid arthritis. We can aspirate some of the synovial fluid via what's called arthrocentesis. The process of aspiration of some synovial fluid from the joint is called arthrocentesis. We can analyze the synovial fluid to find high count of white blood cell, usually more than 20 to 25,000 per microliter. And after that we do some imaging like X-ray, which can confirm the diagnosis, but it cannot only diagnose the rheumatoid arthritis, especially in early stage. Then comes to the new mode of imaging like ultrasound and Doppler, which can diagnose as early as possible, but it needs experts in doing the tests. And the magnetic resonance imaging, which can diagnose some early cases of rheumatoid arthritis. This table is an example of how to diagnose and classify the arthritis. This is a table developed by year 2010 to classify the rheumatoid arthritis patient. and you can find on the left side of the table the manifestation and the investigation, and on the right side the point given for each of them. So you can collect the items, and if you get 6/10 or more, you can classify the patient as rheumatoid arthritis. Of course, you are not requested to memorize all of this, but to have the idea that how can we diagnose rheumatoid arthritis. After that comes the disease-specific treatment, which is called disease-modifying anti-rheumatic drugs, or DMARDs, which can be classified into two broad categories: the broad-acting, which are synthetic in origin, and more selective type, which called selective biological disease-modifying anti-rheumatic drugs. By broad-acting, that means the treatment can act on the active cell and the resting cell. The resting cell is a normal cell, not disease cell. That's why this category of drugs has more side effects, because it affects both the disease cell and the normal cell. Normal cell like blood cell, hair cell, and so on. That comes the side effect of the drug. The second category is the more selective biological, which is most recent and more expensive and promising drugs, because it targets a part of the immunological process, like tumor necrosis factor antagonist, interleukin 6 receptor antagonist, interleukin 1 receptor antagonist, and so on. Therapeutic agents are used in treatment of rheumatoid arthritis. Some of them is just to suppress the inflammation, like the non-steroidal anti-inflammatory drug and the corticosteroids, and some of them can alter the pathway of the disease, which is called disease-modifying anti-rheumatic drugs. The disease-modified anti-rheumatic drugs are of two types, either synthetic in origin, and the other type is more selective, and it is called biologics. Many development is issued in these types of treatment, and with many drugs. Medical treatment or the drug remain the cornerstone of treatment of patients with rheumatoid arthritis. As I mentioned before, the MARDS is the disease-specific treatment. It's either broad DMARDs or synthetic DMARDs, or specific or biological DMARDs. The choice of this drug depends on the disease activity, the level of the function of the patient, which is he's active or living sedentary life, and other lifestyle consideration, like if we have a woman who is pregnant, which drug you will choose for her. And other factor which is not mentioned here is the economic status of the patient. Then coming to our second example of affection of the joint, osteoarthritis of the knee. Osteoarthritis of the knee is very common, as we will see. Each one of you has one of his relatives um, who has knee osteoarthritis, because it is the most common cause of disability in adults. And why it is important, though it is not that hazardous disease, because it decreases the work productivity, and it affects the activity of daily living, and it is a major cause of morbidity and a frequent cause of sick leaves in the working uh, people. And it is one of the highest medical expenses of all arthritis condition, because the disease itself and the sequelae it causes on workers. And it is estimated that at least 1/4 of the population above 60 have symptomatic knee osteoarthritis. In comparison to rheumatoid arthritis, which is a disease of synovial joint affecting the synovium inside the joint. The knee osteoarthritis is a disease of the cartilage, affecting the cartilage inside the joint. And as all we know that the cartilage is avascular, has no blood vessels, and neural, has no nerves. So any loss in the cartilage is crucial. The knee osteoarthritis can affect the three joints of the knee, the patellofemoral articulation between the patella and the head of the femur, and the medial condyles of the femur and tibia, and the lateral condyles of the femur and tibia. The three joints can be affected. And it is mainly a wear and tear problem, but the process is inflammatory, and there are many biomarkers and many inflammatory markers are released. The cause actually is the integration between the mechanical cause and genetic causes and other factors affecting the integrity of the joint. This diagram showed the effect of osteoarthritis on the cartilage. Why not all people develop osteoarthritis? In some other words, why some people develop more osteoarthritis rather than the others? Those are the risk factors causing osteoarthritis. The age. Of course, it is a sort of aging disease, so all people are more prone to have osteoarthritis rather than the younger one. Being female also is more prone to have osteoarthritis. Those factors are inevitable or uncorrectable factors, but obesity comes on the top of most modifiable factors. Obesity is a major risk factor of having osteoarthritis. And previous history of injury, malalignment of the knee. By malalignment, I mean the bone is not in the typical anatomical position. Any deviation on the normal anatomical position is called malalignment. That causes different pressure on different points of the joint, which causes early osteoarthritis. Also, the people who are involved in repetitive knee bending or high impact activity, like the people used to do juggling and other activity with high impact activity. Also, if there is muscle weakness, especially around the knee, that causes early, is a risk factor also of having early osteoarthritis. The patient with knee osteoarthritis comes mainly with knee pains. It can also present as some knee swelling because of inflammation, some stiffness, which is not more than 60 minutes compared to that of rheumatoid arthritis, which lasts for more than 1 hour. And also the diagnosis of knee osteoarthritis is mainly again comes to the history of the patient, and then by clinical examination, then by imaging study. And how do we manage a case of osteoarthritis? If we went to the risk factor, we can do just lifestyle modification, some lifestyle modification by decreasing the weight, treating the obesity, and then improving the activity of the patient and preventing other risk factors like high impact activity, and by some medical and surgical treatment, which is not the mainstay, because lifestyle is the mainstay of treating and preventing even the osteoarthritis. To rheumatoid arthritis, which is diagnosed mainly on history, clinical, then with some blood tests. Osteoarthritis is diagnosed with history, clinical examination, then imaging. There is no blood test to diagnose the knee osteoarthritis. And X-ray for osteoarthritis can detect some cases of osteoarthritis. And in this case, you have to get more than X-ray in different planes. The X-ray features mentioned in this slide you can detect in the next slide. The osteophytes means new bone formation around the joint. Then the joint space, decreasing the joint space means loss of articular cartilage. Then you can see in the two arrows, right arrows on the right side of the photos, the subchondral sclerosis in the white arrow below, and the subchondral cyst in the right arrow above. Those three X-rays shows the development of knee osteoarthritis from normal knee to moderate osteoarthritis, then to severe osteoarthritis. The space between the two bones marks the cartilage. So with decreasing the joint space means there is loss of articular cartilage. How to manage a case of knee osteoarthritis? As I said before, lifestyle change is the mainstay. You have to instruct your patient to lose weight by referring him to a nutritional expert or specialist. Then you ask him to do programmed exercise and physiotherapy referral. He can ask him to do quadriceps strengthening exercise, range of motion exercise, and you advise him to do low impact activity. By low impact activity means that he cannot, he can exercise without loading his weight on the joint, like swimming. And also you can advise him with ambulatory assist device that you will see in the next slide. And also you may advise him to have insoles, that is the part on the part inserted inside the shoes to correct the malalignment. And of course also you can ask him to use knee braces, as you will see in the next slide. Compared to rheumatoid arthritis, when medical treatment and drugs comes first, then the lifestyle comes first in the knee osteoarthritis, and next to the lifestyle modification comes the medical treatment. So in rheumatoid arthritis, the mainstay is medical, while in knee osteoarthritis, the mainstay is lifestyle change. What are the medical treatments of knee osteoarthritis? Actually, there is no curative treatment of knee osteoarthritis as far, but we can use some glucosamine chondroitin, which is the normal forming part of the cartilage, aiming to restore or preserve the cartilage, and the others anti-inflammatory option or pain killer. Also, we can use some intra-articular injections like the hyaluronic acid, which is the normal synovial fluid uh, component that can resorb the synovial fluid, which makes like a lubricant between the two joints and preventing further development of the disease. At the end of this presentation, I would like to thank all of you, and I'm waiting for your all questions on this email, and hope you all